CME on Principles of Wound Management. As you know, Home Nursing Foundation have been serving frail and vulnerable homebound patients for the past 46 years by providing home healthcare services such as home medical, home nursing, home therapy, and home personal care. We also have 2 senior care centers and day rehab, which is situated in Hougang and Buangkok, and 1 active aging center to serve the needs of both dependent and well seniors in the community with the aim to improve their function, health, and overall well-being. Under the prolific leadership of Dr. Ng, our medical advisor, we have the privilege of organizing a continuing professional education series relevant to the home and long-term care sector in order to raise our capabilities to care for our patients holistically and also to empower them to live joyfully in the community. We have just completed a series on the end-of-life care for frail elders, functional rehab, dementia, mental health, and falls and osteoporosis, and they are available on YouTube videos on the QR code link that you will see in the slides. We also warmly invite you to attend the Caregiver Conference on 6th of October this year at Suntec Convention Center as we launch our Care Path on caregiver support in the community and invite experts, practitioners, caregivers to share their perspective and experiences. So please mark your calendar for 6th of October. And this afternoon, we are very privileged to have Dr. Wilson, who will be sharing with us principles of wound management. And I'll let Dr. Ng take over to introduce Dr. Ng. Thank you.
Thanks, Christina. So this afternoon, we're very privileged to have Dr. Wilson Chong. He's a very senior emergency physician. I know him for many years when I was serving in NS. And now he is, apart from helping HNF caring for our homebound seniors, he's also leading a private clinical medical center as his medical director. So today, just a very brief, very brief introduction to Dr. Wilson Chong. He was trained as an emergency physician and worked in many countries, including UK, Israel, and Brunei, serving both the public and private hospitals. He subspecializes in disaster medicine and currently has a passion for wound care. And I witnessed him, how recently I had a patient that he went to the house and do a very expert nail avulsion, and then he's got all his equipment with him and then doing a very good wound care, and now the patient is very happy in UK. So anyway, without further talking, okay, we have Dr. Wilson Chong to share on the principles of wound care, and we will hope to have some time at the end of it, maybe 5 to 10 minutes for Q&A. So if you have any questions, you can type onto the Q&A. So Wilson, please.
Hi, good afternoon, everyone. Thank you for joining me, and I'd like to thank personally Home Nursing Foundation for allowing me to discuss wound care on their platform. First, I must declare that I'm an unwilling participant in wound care initially. Now, these 2 guys who has a free accommodation at my home, free food, and then the supreme commander of my home also expect free medical care. So this is how I started off having interest in wound care. Every few days they will come home with some scratches, some falls, some skin abrasion, or even bad wound. So that's how I started. Subsequently, of course, I joined the private sector for a while, and that requires some of this wound care management. And then, of course, later on, my dad is bedridden, and then my sister has cancer. So all these things inspired me and also pushes me on to have a special interest in wound care. Then, of course, now it's because being pressurized by Sister Serena, then I'm here today. Right, today the topic, we will do a brief introduction, and then after that, it will be pathophysiology of wound healing. Then we briefly discuss on the type of wound, and then the core of this discussion will be strategies in wound management. Right, let me first introduce wound care. First, I think we should refresh our perspective. Well, does wound healing occur at one stage? Because all of us just, the usual is that we slap some dressing and then we expect it to heal without any other expectation. So are all the wounds same? Whether is it because they are old, they're new, they are small, are they all the same? And lastly is that it is too expensive and troublesome to do otherwise. So I guess we need to look into this when we embark on this wound care journey. Okay, actually the pathophysiology of the wound healing is a little bit complex, and but I will not go into detail into cellular level. Basically, it is a continuous process, and many processes can simultaneously begin. And however, there is a continuum, okay, continuum. So actually, if you look at it, this is not the end. 14 days is not the end. It actually extends up to 6 months. So this is a simplified way of looking at it into inflammation, granulation, wound contract, and then collagen accumulating and remodeling, then it's up to months. However, the wound can stuck in certain stages. Sometimes it actually goes back. For example, we always put TG on wound, but if we neglect it for a few days and the wound, the dressing dries up, then we tear open it, then we actually restarted the whole process again. So this is things goes in vicious cycle, and of course the wound doesn't heal, and then after that we have more scarring. Okay, yeah, I'm talking about acute wound actually. Okay, this is a picture that illustrates what we have discussed. So it just gives us a visual of what is happening. And this is what I download actually from internet. So you can see from acute wound to chronic wound, or rather to healing process, how is it like generally from immediately until day 30, right? So like I said, wound can stuck in certain stages. They do not progress, or they got worse, or they can go back to stage 1 or initial stage again. So we need to be very aware of the wound healing process. So to answer the question is, does a wound heal in all 1 stages? The answer is no, obviously. Now, I will also not go into the details of classification of wound or type of wound. Basically, the wound are being classified in many ways. There's acute or chronic, but we need to understand, or we need to remember that acute wound can become chronic, and chronic wound can become acute wound. But sometimes making a chronic wound to acute wound is intentional because we want to stimulate the healing process. Then they are by mechanism, like for example, penetrating, whether there's a dirty or clean, simple or complex, and depth. Okay, so what we do is that we will talk about, let me go back to this. To go into this type of wound, later I'll explain as we go along the strategy that we may look into this, especially during the assessment. This will determine our action, our path of this management strategy. Okay, there's actually 8 A's in this wound management strategy. I know it sounds very difficult sometimes, but as you go along, if you start to practice and to put all this, that means every time you look at a wound, you go through the steps, then after a while, it becomes a second nature. That means you, without doubt, you will go through it yourself. So first A is assessment. Of course, we look at the wound, the appearance, the anesthesia, and aseptic. Apposition means how to close the wound, which might not be applicable to the chronic wound. And then application, which is the dressing, antibiotics, and aftercare. Then after that, of course, after 8 A's, you get an A grade result. Okay, hopefully that will happen in every wound that we see. Right, let me go into assessment. First, there's 3 circles in this. We have to assess the patient factor, the wound itself, and the caregiver factor. Patient, obviously, we need to know whether the diabetes is not, whether there's peripheral vascular disease, for example. In elderly, is it because of postural dependent, that means it's bedridden and cannot move. But there are other factors that is important. For example, if the patient is steroid, then sometimes the wound doesn't heal as well. Or is psychogenic. That means every time the wound is going to heal, the patient peels it, right? Whether intentionally or not intentionally. Then that's why you keep ending up seeing wound that is, it puzzles you because the wound end up, every time you see it become fresher than the last time you saw. So you need to understand or rather look for all these causes. And I must stress that, for example, diabetes, if the patient does not, even is borderline raise the sugar, blood sugar, or not very well controlled, but it's not that bad, wound can be impeded. Wound healing can be impeded. This is an important factor. Right. Then the wound assessment. So it's a ABCDE. This is quite fundamental for us. Later I'll briefly talk about depth and age. I'll show you some example. Okay, so wound assessment is important where it determines our approach, prognosis, and fundamentally how it's going to progress. Remember that okay, never mind. I'll skip this part for a while. Later I'll go to the next slide, then we can talk more about it. Then caregiver, beside medical staff, whether the doctor, nurses, or is confident in looking after the wound, whether they have planned for the wound, they can manage the wound. I have met medical staff that they don't like wound at all. They look at wound, and then they put something and walk away. There are people that there are some of us who are so-called naturally we swing to each direction. That means some are more medical, some are more surgical. But nevertheless, I think it's quite fundamental that we need to have a good understanding. Then actually, then we can plan for the healing process. Next of kin, similarly, if you assess the next of kin, that means they don't like to touch, they don't want to know anything about it, then we are in for a hard time. All right, everything pushes to the helper, then it's going to be depending totally on the helper. So there's also certain helper that they are easier to educate. It's easier, they know what they are doing. Then the path is easier, if you're totally depending on the helper. So these are also some of the important factors that we look at during our assessment. Now, for the ABCDE, the depth of the wound often determine the prognosis, often determine what we can do, and scarring. Right, the deeper, obviously, the deeper it is, the more scar it will be, and more difficult to heal. The more superficial, then you will not be. The scarring is better, healing is faster. All right, so assessment of wound is the depth of the wound is important. So have this picture in your mind that when you assess the wound itself. Okay, so let's have a few picture to illustrate what we talk about assessment. So what do you think of the first on the picture on the left hand side? What kind of wound is this? What do you think that what is the prognosis of this wound? So when you look at it, so I pause for a little while. So let this maybe we can go through in your mind. You look at the A, B, C, D, E of this thing. Okay, so first the appearance, is very red. It's quite pinkish, and then there's no, like pus or stuff on it. Okay, so you look at it in general, it's quite deep. It's deep to subcutaneous, and the location is, in the medial side of the ankle. And if you look at the edge, it's very straight and punched out, it's straight in. So this is an ischemic ulcer. All right, so once you know that, then you know that this wound is fairly stable, but the healing process is going to be very long, or if not, it's almost impossible. Okay, unless we do some grafting or some what they call revascularization. Okay, Okay, now let's look at the right side. This elderly lady, he has a wound on the face. What do you think? I'll pause for a little while. So we go through, you in your mind, you go through the A, B, C, D, E. Okay, so if you look at it, it's on the face, nasolabial fold. It's irregular. The wound doesn't look too bad, like a little bit dry, but the edge is very irregular. We are not sure whether it's pigmentation or there's a blood clot. So this is a basal cell carcinoma. All right, so this wound will not heal because it's cancerous. All right, so this lady does have this, and whatever it is, we are just controlling the symptoms. So unless it goes for excision, right? So this wound will probably not heal well. In fact, it will extend as time goes on. Okay. Yeah. Do you have if you have any question, you can put it in the Q&A, so we can. I'll do my best to answer you. All right. Anesthesia. Now, first, it is important to provide. You notice that I'll put this at a second after the assessment, because I often we all touch the wound, or we try to do something without providing painkiller. I think this is, to me, is a no-no, because the patient doesn't feel good, has a lot of pain, and then resulting in movement, and you can't assess or look at the wound closely, or even do other things. So I will actually provide pain relief first. Some people say that if you provide, some people will wash the wound first before you provide anesthesia. I don't do that, because firstly, if I wash the wound, you already started the pain process. So usually I give painkiller. And in my experience, when you give pain relief, it does not increase your chances of infection. All right. So we start with topical. We actually can put topical onto the wound. Basically, you look at this, is a xylocaine. This is the one that is 2%. We have 1%. You know, the usual that you inject for local anesthesia. And this is a liquid form. If you look at the third picture, is lignocaine with gel. This is the one we put in catheter. All right. So which one? Okay, the normal one is 1% lignocaine. This one is 2%. Which one do you think works better? Okay, most people say 2%, right? Because percentage higher. The answer is no. Actually, personally, the liquid one, the 1% works better. But you need to seal it off. You apply onto a wound. That means you drip this onto the wound. The patient will have a smudging effect. That means have pain. Then you seal it off with a techadum. You hold it for about 10 to 15 minutes. Then after that, you can, do what you want. So this one actually works better than you put gel. Okay, but of course, you still can put gel. You also can seal it off. The lignocaine 2% gel is thicker. It's better if you can retain in some cavity like the urethra for mucosa area. Okay, so my first choice would be topical. I will use this. Then I put the techadum before I do dressing. All right. Okay. So you still need to bear in mind that the toxicity or toxic dose is 3 milligram per mil. So it's just per 3 milligram per kilo. Okay. So you need to be aware of this. Okay. EMLA, we use it on skin that doesn't have wound. So, usually it's not recommended unless you're very desperate on using a topical. Okay. Now, when you put topical, it's not for sharp debridement. It doesn't, because once you put topical, then you seal it off, then you have pain. Then this is for you to do dressing. Then you can quickly do dressing. And the pain relief actually will last about a few seconds, maybe 10 seconds. After that, then the patient will start feeling pain. So topical is only for like dressing, but it's not for sharp debridement. Okay. Right. Then we talk about intralesional. Of course, we are all very familiar with 1% lignocaine. Like I said, remember that use 3 milligram per kilo is the maximum. That in a 50 kilo person usually is about 3 valve of the lignocaine 1%. What I also use is lignocaine with adrenaline. This is a dental preparation. The adrenaline is 1:80,000. So this is good. You can mix it. That means you can use this plus a little bit of lignocaine. It has a good function because it causes vasoconstriction and then less bleeding when you do sharp debridement. But some people do feel palpitation. Some doctors feel uncomfortable because they say they are elderly. So you use it in moderate amount. This is 1.8 ml. You can mix it with, you can use concurrently with the 1% lignocaine. One valve of this adrenaline with lignocaine is same, is 50 milligram. So same thing, you can use 3 valve. But like I said, that a lot of us are concerned about palpitation or increasing the heart rate. Now, let's say you want to dilute your own lignocaine. So what we do is that you can use 1 ml of adrenaline, the one you use for resuscitation or cardiac arrest. Then you put in 100 ml normal saline. You know those 100 ml that you put in for antibiotics. You can inject 1 ml inside. Then you will get 1:100, which is similar to this dental preparation. But this dental preparation will be higher concentration. It is 1:80,000. Whereas in your adrenaline, the one you prepare is 1:100,000. If you want to further dilute it, 1:200,000, then you put half a ml in 100 ml of normal saline. Right? Quick and easy to remember, right? Now, let's say you don't have so much normal saline, you want to use 10 ml. Then you use 0.1 ml of the adrenaline into 10 ml of normal saline, right? That will give you also 1:100,000. Okay? So it's easy to remember. So that when you do sharp debridement, then you don't have a lot of bleeding. All right. So after you give, you probably need to hold about 10 minutes to 20 minutes. When the vasoconstriction effect comes on, then you can start to do your sharp debridement. Okay. Then the other thing I need to stress is that be careful. Don't give it at the end organ, which is like finger, nose, or penis. So because vasoconstriction can cause terminal gangrene. Okay. Now, if you look at the right side, often we are taught, right picture, taught that you do not give the injection into the wound because you're scared that you push the contamination further in. Like I said, this is not the case. I've been doing it in the wound because I do not want to create more holes. Okay, if you really feel strongly about it, then you can, but make sure that you go around the wound and keep a distance. All right, because if you're too near the wound, then you defeat the purpose of causing cross-contamination. So we will probably be about 0.5 cm to 1 cm away from the wound. Okay, but I say again, in the wound itself, if you give it intra-wound, it doesn't create extra hole. It also, and for me, it does not increase my chance of infection. Okay. And also, if you do it around the wound, remember you need to prep the wound around the skin around it using alcohol swab. Okay, not into the wound, but prep the skin around it. Then we do the injection like our IM injection. Okay. All right. Okay, so as aseptic or debridement. So this is the single most important factor in reducing infection. Okay, I stress this. This is the most important factor, not our antibiotics. This is, in a military term, it's like shouting the enemy holding using missiles, artillery, or airstrike. Then you soften the ground. Okay, so debridement before our antibiotic, which our infantry can move in to take hold of the area. So this is very important, the single most important factor. A lot of people has not done this enough. That's why the wound get infected. Or sometimes, let's say it's a bite wound. That means it's a very small entry. So you did not clean adequate enough or debride enough. That's why this happened. The infection happened. So this is a single most important factor in reducing infection, not antibiotics. Remember that. Okay, at this point, I'd like to introduce the concept of biofilm. Of course, a lot of us know this already, but sometimes we forgot. But basically, the biofilm is a 3D structure that, it hides the bacteria. So the bacteria can hide below, okay, just like a bomb shelter. So we need to remove this, because if not, then they will stick to it. And whatever you give doesn't reach there, because these are all dead tissue, dirty things. And dirty thing or dead tissue don't have blood supply. So your antibiotic will never reach there. So whatever you give, however strong it is, there's no use. So this is an important concept When you see biofilm, you need to remove it. Okay. We can use two ways: medical debridement. Later, I will briefly discuss on this, and surgical debridement. Okay, surgical means you cut it. Okay, medical means you put something, and then after that you can soften it and then wipe it on. Okay. Right. Again, let's look at this wound. This is a lady. This is a fairly new wound, about 2 weeks old. What has happened? This is actually she stand behind an exhaustion pipe of a motorcycle. Okay, so she had burns, but it get worse. And subsequently, can you tell that around it or on it, there's yellowish things? So her wound doesn't get better because all these yellowish things, they are biofilm. Okay, so the things are hiding below and it can't get well. So we need to remove the yellow thing. Now, remember that just now we have discussed about the process of wound healing, the stages. So what happened is that we are stuck. So we have to create or refresh the wound back to day one. It's like, almost like your computer got hanged, then you can do the control alternate delete. So you're back there. Then you restart. That means you need to recreate the wound again. That means you clean it up, okay, scrape it off, or you want to use medical debridement. Then we recreate wound back to first day. Then we can restart it again. Okay. Then healing will progress. Next, on the aseptic or debridement topic, I would like to briefly talk a little bit on the solution. Okay, iodine is probably the most misunderstood child of the family, right? A lot of us think that it is toxic lah, is dirty lah. You know, iodine is only for things that is unthinkable. Yes, I agree with that because I have seen this 30 years ago where they do a chest tube and then they put iodine impregnated gauze onto the chest, around the chest tube. And 3 days later, when I take out the gauze, the skin came off with it. So I'm not sure 30 years ago, what is the preparation? I've forgotten. But it is believed so. That's why a lot of people don't like to use iodine. I'm talking about pure iodine. So now the preparation is povidone iodine, usually about 10% concentration. So actually, it is the best weapon we have on the solution. It is like the nuclear bomb. Everything goes, all right? And it has, later I'll show you the evidence of this. And well, it was discovered much earlier in 1839. So it's been used since then, okay? But like I said, it's the most misunderstood. Only the recent year has resurfaced again, okay? It kills yeast, fungus, virus, gram-positive, anything, okay? It kills almost everything. This is a good weapon that we have. Alcohol. Now, alcohol is also very good. Both alcohol and iodine works best when it's dry. But alcohol, remember, cannot put on wound. When I've seen people put, you know, some of our alcohol is blue color in the hospital or clinic setting. It is the same as chlorhexidine color. So be aware, if you pour alcohol in the wound, the whole wound will turn white. All right, it's almost ready to be eaten. All right, so it's amazing. So the toxic effect is almost immediate. Of course, it's a very good antiseptic, but remember, never put it on the wound. In fact, in the place I'm practicing, I have taken it out. What I meant is that I have make sure that the chlorhexidine comes in pink color and the alcohol is blue, so that we don't have a mix-up, you know, because people may not read the label. So this is a really important warning. Do not misunderstand that alcohol can put onto wound. Okay. Then next we come to chlorhexidine. Is very well used. It's discovered in 1950s, broad spectrum. There are some claim that it's good for yeast and fungus. I'm not sure about that, but generally it's very good for gram-positive. People say that the gram-negative is also susceptible. Normal saline. So we often use normal saline after everything. Why? Does it has any function against microbials? No, it does not. Basically, it's load reduction, and you prepare the wound to be sealed up. That means like you stitch it. After that, you put a dressing on it. Okay. Lastly, I'd like to briefly touch on hydrogen peroxide and USO. We used to love using hydrogen peroxide because we poured it and it got bubble come out and it looks so exciting, right? We use it to, last time in my time, there are some maggot infested wound. We pour it inside, then you see the maggots start jumping out and so you feel so excited. Yeah, but again, this is also out of favor now. USO contains sodium hypochlorite, which is now used as an antiseptic hand wash. Sometimes we use toilet to wash toilet with it, and this is also out of favor now. Okay, so I hardly see people using, and nobody has mentioned USO. During my time as a house officer, it's very popular. Okay, sorry to go back. When you put iodine and chlorhexidine, some people also say the disadvantage iodine is causing pain. But personally, clinically, I feel that I tried before putting iodine and chlorhexidine. Both patient, the reaction is the same. They feel pain for a while. Okay, and the important thing also is that when you put iodine, you need to, and chlorhexidine, you need to let it soak for a while. Okay, later I'll come briefly to it also. You need to soak for, not put and then immediately wash off. It doesn't work that way. Okay. The iodine also, yeah, so I forgot to mention that iodine works by penetrating into the microorganism, then and oxidizes the key protein and micronucleotides and fatty acid inside and eventually leading the cell death. Okay, so it works very well in that sense. Okay, so if you look at it, I've included some of the articles and studies. You can look it up if you're interested. Basically, the efficacy on all these antiseptic solution is that depending on one, contact time and organic load. So contact time meaning that you need to put there 3 to 5 minutes. The longer, the better, and then it works more effectively. But don't forget, contact time also depending on whether you can access to location. If you have a small puncture wound, whatever you flush outside will not get in, so it doesn't have a contact time. Whether it's the right antiseptic, whether it has the consideration also, whether the concentration is enough. You know what I mean? So let's say you put 100% pure iodine, of course it works better, but of course it's toxic to the tissue, right? So 10%. But if you put lower than that, does it work like 1%? Maybe not. So all this contact time depend on several factors as well. Then organic load, like I mentioned, that the load of the bacteria, and the next thing is the biofilm. You need to remove it because whatever it is, if you have a biofilm there, the organic load will be high and they are not accessible for contact. So it doesn't work. Okay, it's just a simple understanding. Okay, yeah. So just to illustrate that all this is actually one of the, unfortunately, it's not intentional, but it's one of the best randomized control trial. This young lady, a young girl, she is volunteer. She wants to be a vet, so she volunteered in a veterinary clinic. But unfortunately, the cat attacked her. So the cat bite her, not claw, bite. So but because the vet is very anxious, because after all she's an intern, she's young, 15 years old. They scared the mother come after her. So the vet who brought her in is very agitated. So what happened is that they decided for a plastic consult. So I instructed my young colleague to irrigate the wound. But the young colleague irrigate the upper part, thinking that, oh, this is more serious, but did not irrigate the lower part. Okay, so you can see that the effect this after 3 days. Okay, after 3 days, okay, unfortunately, when she go to the plastic side, the doctor, one of the younger colleagues saw and said, oh, never mind, can review in 3 days, just dressing can. So you see what happened 3 days later? The lower wound are all filled with pus. The upper wound has no pus. Okay, just because we irrigate once. So this can you see the effect when you do a proper antiseptic or washing, Okay, so the correct way of doing this is to actually irrigate, debride. If you need to, stitch it. That's fine. Animal bite on the face can be stitched. Irrigate properly. If you don't want to stitch, that's fine also. In 3 days' time, then you can do a secondary suture. So, but this example or this case illustrate how antiseptic solution work, how well it works. See, look at it. Below is all pus is oozing out already. This is only about 3 days later. Okay, and also upstairs there's a bit of inflammation, but there's no pus. Okay, so antiseptic and debridement is a single most important factor in determining infection. Okay, this is slightly for apposition. It may not applicable to the chronic wound. We have a few things like tissue glue, sterile strip, and suturing. This is to close the wound. Now, both tissue glue and sterile strip, the manufacturer says that they're equivalent to a 5-O-proline strength. That means the strength, but it needs a proper opposition. Glue, remember the tissue glue is not to fill up the gap. You must actually push the wound together, seal it off, and then wait for it to dry, okay, for a while. Then you let go your hand so that the wound will not spread open. So I also have a colleague who used the glue to fill the gap. So obviously next time there will be a big wound or big scar, okay? This is not the intention. Also be careful that don't use it around the eyes. If it's on top of the face, then you need to recline the patient in triangular lumbar so that when it leak, it goes down on top of the head. If you on lower part of the eye, then you make sure the patient sits slightly upright 30 degrees. Because I have seen tissue glue got into the eyes before, okay? And that is a nightmare, I can assure you, okay? Then sterile strip. What is the trick to sterile strip application? It is that you must treat it like a suture. That means once you stick it, you must be removed after the stipulated time for STO on that part, like face is 5 days, hand is 7 days. It is not a dressing. Don't treat it like dressing. That means you can, tomorrow you review, then you take out the sterile strip and reapply. It doesn't, because you keep resetting back the original, the wound healing process. That means you bring it back to first day, then the wound will slowly open, then you just close it back, open. Okay, don't do that. You treat it, unless it's infection going on, it's pus and all that. Otherwise, use it like a suture. Stick it, keep it on the stipulated time that you want. Okay? And then I will not go into suture, okay? Suturing, which is the next time maybe we have chance now, then we talk about it. All right, if you look at this example, there's this old lady scraped the hand. So you see the skin come out, right? Okay, now you assess the wound is fresh. It is on the hand. You can see to sub-Q, all right? What else do you see? So in this point, the depth is very important. The assessment is very in the epithelial layer. Can you see that? Yeah. So what do? Cut the skin away. Don't do that, because don't cut this slab of skin is the cheapest non-allergic. Okay, in fact, it's free. The non-allergic, okay, the best, most natural dressing you can ever find. Okay, you have to, sometimes if it comes to you, if the patient comes, or you went to see the patient after hours, the skin may be dried up. So you soak it saline, you roll it back. The furthest I roll is from the hand to the elbow. I have rolled such a distance before, and you will heal perfectly, actually. If you look at it, you see, you can pulse it properly, and you apply sterile strip. This one will heal fantastically without scar. And also, you put absorbent dressing like a foam on top. Okay, then you just wrap it up. And you keep the sterile strip for 7 days, it will heal wonderfully. Okay? Yeah, so remember, don't cut the skin. Don't cut the skin away. It is one of the best dressing I can ever recommend. Okay. All right, so you can compare. If I roll it back, you can see there's a hole, and then if not, there's a defect, the big piece of defect. Yeah, when you're doing before you roll it back, of course, you must wash it with some iodine, chlorhexidine. You lift up the skin and wash it below. Okay, make sure things don't trap below. Okay, dirty thing don't trap below. All right, so next thing we come to application. It is the choice of dressing. Actually, we always revolve around balancing moisture. This is the most important. Of course, when we look at dressing, antimicrobial is a very important consideration, and hemostasis. A lot of people say that, oh, moisture is good. Okay, so they put Tecadum. Tecadum is the one that I show you, transparent, which is good. But the problem is that Tecadum trap sweat around it. All right, but you said sweat is good, what? It's moisture, right? Yeah, but sweat is excrement. We don't want it from our body. So you put it on a wound. It doesn't work well. You just as well might as well use urine to wash the wound because it's also, aseptic and then it's natural. No, it doesn't work that way. We are talking about balancing moisture, but it must be the correct type of moisture. It's not like excrement. So I personally do not like to put Tecadem on wound because it doesn't breathe, it traps moisture, and its surrounding will be macerated. Okay, so balancing moisture, you must put in the right context. Remember that. Okay, so that's why. Okay, so now let's look at a characteristic of an ideal dressing. Okay, it has many factors to consider. It is almost like getting marriage and choosing a spouse. Okay, and unfortunately, the ideal one doesn't come along. Okay, so there's no perfect dressing. It's the most suitable at a point of time in your setting. Okay, just like your spouse. Okay, I hope my wife didn't look into this. Anyway, so firstly, you need to, like I said, the humidity. Okay, on the same time, you need to remove excess sudate. Of course, it's not supposed to have toxic or wound contaminant. Okay, non-allergen, protecting the wound. Then remove without causing trauma. Okay, remember we used to use TG. TG is good because the paraffin or the oil prevents the wound from drying. Okay, but the problem is that you leave it there for a few days, it becomes kicked up, it becomes hardened. Then when you remove, it causes a lot of trauma. Okay, so again, this is in context. But it's, of course, a very cheap form of the dressing. It must be impermeable with bacteria, thermally insulating. Okay, in our context, not so applicable because we are in a warm country. We supposed to allow gaseous exchange, comfortable and conformable. Best is require infrequent change, cost effective. Then if it's in general practice or in where cost is important, it needs to have a long shelf life. Okay, there's no point having a dressing and we don't have a lot of flow. You buy a lot of this dressing and then it's expiring in 2 months. It's quite it's not so economical viable. Right, so basically we divide dressing into 3 main types: passive, interactive, and bioactive. Passive products is like our traditional gauze, TG, and all that. Sometimes, okay, just before I explain, we talk about dressing. These are all the simple classification, but to make it more complex, the vendors or the company will add certain product into certain product and then they plus another product. So it becomes very complex. That means this product originally is passive, but then they add something active inside. Okay, so don't get confused. So passive, we are talking about this basically gauze and TG and all that. It does nothing. Okay, but of course people add iodine into TG nowadays. So it's an antiseptic. Okay, it's a TG dressing basically. The interactive means that it's supposed to be permeable, non-permeable to bacteria. Then you have foam dressing is the less interactive, is an interactive one. But sometimes they add silver ions inside. So it becomes bioactive. It releases this silver ion. Silver ion is antimicrobial. Okay, it goes back into the Egyptian day. They say that this ion prevent it is for mummification. So of course we don't use it for that purpose here. Okay, unless you feel very strongly about it. Okay, bioactive product means that the dressing will actively contribute. So you have hydrocolloid, alginate. I'll briefly talk about some of these later on. Others will include silicone and honey. Silicone basically is those that you use to make it impermeable to water. For example, like your sink. You go home and see the sink. It comes in transparent white or gray form. It's lining the sink lining. This thing is flexible. You apply on it, it dries. It prevents water from seeping through. Okay, people use honey impregnated into the wound dressing because honey is the only thing that doesn't decay naturally. That means you can put honey into room temperature and doesn't decay. So there's a lot of antimicrobial and goodness in it. Okay. Of course, there are other things like charcoal so that you will not have so much smell. Some people actually, their type of dressing, they use it to stop bleeding. It contains the shell of the crustacean. It is like prawn or this. Okay, so it stopped bleeding. Is one of the things that they use in military overseas and all that. The other type is that they use it for what is the thing that is for diarrhea? I forgot. We use it for diarrhea to take. Sorry, the word just skipped me.
Is it smack?
That's Mecta.
No, the last time one, not charcoal. Before they use it for
Oh yeah, the kaolin.
kaolin. So one type of dressing. Yes, thank you, Dr. Ng, for saving my day. So they put kaolin into the dressing. Kaolin has hemostasis property. So that means you get shocked, you put it on, press it for 10 minutes, it's supposed to stop bleeding. Also have. But these are all slightly outside our scope, which I will not discuss today. So you can see that actually they put honey inside. Okay, silicone, it comes in a plaster form, or it can be a gel form, which is this. Okay, this Stratamed is the only brand, only silicone they have put in a fresh wound. The rest are all for scar management. Okay, there are other brands also. Okay, I'm just taking it for example. All right, let's go on to this what do you call it, application. Let me briefly, there are three main types in the market. Hydrofiber, this can absorb up to 30% of their weight. This actually is a carboxy metacellulose. Okay, it retains moisture, and then after it becomes gel or agar-agar like, you know. Now this is supposed to be, then it's very good because it can fill up the cavity. You can fill up, and then the fibrin collects between the dressing and wound. It acts as adhesive. It sort of kind of fix the dressing inside the wound. Okay, but because it's a vertical fluid absorption property, that means it sucks fluid straight up, so it does not cause surrounding to be wet and less maceration. These are all the advantage. But you need a secondary dressing. That means you need to put a gauze or something on top. Because it's gel-like, after you pack in, it sometimes can be difficult to remove all. Okay, but of course the vendor very clever. They come up with other, like they use thread, so that to tie around it, so it becomes a string-like. So you can pack it in and you use the string to pull it out. Okay, then alginate, he has a 20 times absorbent of their weight, less, but it's still a good one. It is actually made from seaweed, brown seaweed. It's a calcium and sodium salt of the alginic acid. It's a polysaccharide, basically. This alginate usually have a hemostatic property. That means it's supposed to help him stop bleeding. So in a wound that has some fresh bleeding, then you can pack it in. Then foam is adaptable. Remember this one you cannot pack because it's a foam. It does not need a secondary dressing because outside is impermeable or waterproof. Okay, but because it's foam, it also has a cushioning effect. It's good for putting at a buttock, you know, place that is dependent. All right, it promotes autolytic debridement because it retains moisture. Okay, foam is a polyurethane base, so it's supposed to be heat and pressure modified one. So after that, it like a sponge like that. But it doesn't stick to the wound also. The disadvantage is that it conforms, but it does not really fit inside like a cavity. Then it's difficult. It's well known, difficult to put on the hand because the thing will very easily move. Okay, because our hand is mobile. Okay. Hydrogel. Someone just asked me this question yesterday. Hey, so what's the difference between hydrogel and hydrocolloid? Actually, both are very hydrophilic. That means they absorb fluid. But hydrogel classically comes in a gel form. That means you bring the moisture into the wound already. Hydrocolloid is come in a film form. So it doesn't have water. So you need to add water, or the wound itself has water. Then it can absorb. So that's the main difference, but they are structurally, although they are different, but functionally they are similar. Okay, remember this one usually comes in a gel form. It comes in a film also nowadays. This one comes in a film form, usually. They have even evolved this into a pimp. You know, the acne, the patch, this is hydrocolloid. Okay, it's supposed to absorb oil, your sweat, then make the thing rupture, a tiny one. These are actually hydrocolloid, usually. Okay, so how they work, same. Hydrogel, because it brings in fluid, it's already had a gel form, so it's autolytic. So you must put in and seal it off, right? And cook it for a few days, then your debridement is the autolytic, that means the medical debridement will start. Okay, it's no point that you put it on and you put a gauze on top, then the gel start to dry out, so it has no function, it has no autolytic debridement in this situation. Hydrocolloid is on the film, they increase the rate of epithelialization, collagen synthesis and decrease pH of exudate, which is good for antimicrobial. Okay, but remember this in the gel is in a film form. Okay, it doesn't bring fluid in it. You have to come, the fluid has to come from the wound itself. And when you put a hydrocolloid like duodenum or some of the duodenum extra thin, you need to put around it 0.5, at least a 0.5 cm. If not, the fluid collected, then the whole bag, it become a bag of fluid, all right, or a leak. And the gravity dependent area must be at least 1 cm. That means on the leg, facing downward, that part, you must have a 1 cm margin or more. Okay, patients don't like this a lot of time because they start to leak liquid out. So sometimes we put a gauze over it to absorb. But this is very good for acute abrasion now and all that. You put on, they become painless. It heals fantastically. Fantastic, really. I use it many times on my son. Okay. All right, so now we have to talk about the important thing now, huh? Sorry, am I running over time? Let me just, okay, oh dear. So this is the single most important topic here about money. Again, I briefly present to you hydrofiber alginate. These are the price to us. I didn't mention the brand name just in case they later they get upset. Okay, this is the price to us, not the price to the patient. One piece 10 by 10 is already almost $12 if you look at it with AG. Okay, so you must cut it. Last time my nurse, a 2 cm wound, he packed a 10 by 10 cm, then he packed a $12 into a 2 cm wound. Okay, he thought that is the norm. But because it is not necessary, because you need to absorb, then they will swell up. Okay, you just cut roughly a 2 cm. In fact, I will save a little bit. I cut 1.5 cm and pack into the wound. Okay, because it will swell up. I save money. But every time they add something and the company adds something, our heart skip a bit because the price increase. Okay, for example, hydrofiber AG, hydrofiber double layer means they put thread to reinforce it. Okay, with AG, you see the price jump again. Okay, this one is no AG, huh? So alginate 650. Okay, you put AG, then it jump $2, huh? Okay, then you put ibuprofen, wow, you jump $8. Okay, so ibuprofen, this is one of the unique. They put painkiller into the dressing, which I think is okay, should not mention here. Okay, foam is, if you can look at it, okay, you can look at it, $4, but you put adhesive one, then you jump. You put AG, it jumps some more. Then foam adhesive sacred art. This, to be fair, is very large piece. It becomes $20. So this one, surely, I don't think we can afford to change it every day. Okay, because one piece, if you $10, $20 1 week is $140. Okay, so this is a big consideration. So after this discussion, don't go and straight away jump into all this expensive dressing, but just to know what it is first. Okay, so we talk about antibiotics. To give or not to give, there's a question, just like Hamlet. Okay, topical versus oral. So usually we always recommend topical if it's not infected. So I will briefly talk about tetracycline and sulfadazine. Okay, fusidic and chlorhexidine, is quite straightforward now, I feel. Then briefly I'll talk about oral antibiotics also. Okay. All right, tetracycline. Okay, I have included this study, or rather this article. If you're free, have a look. Now, this is a very long article. You can have a look, 80 over page. So, in 1969, Boston Hospital already. Okay, this article is a bit confusing. They talk about tetracycline. Actually, not only tetracycline. They talk about tetracycline and tetracycline agent. So, what they meant, tetracycline is actually the first generation tetracycline. Tetracycline agent, they're talking about doxycycline, minocycline, and imidacycline. Okay, so actually in 1969, the first generation tetracycline already has 38% Staph aureus. That's about 50 years ago. Okay, and this is actually talking about oral. Okay, now others, I mean not oral. One, they're actually talking about in vivo. They mean they put the thing. They use it to culture and test the sensitivity. Other study shows that actually Staph aureus resistance is low. Okay, but this is agent. That means they're talking about other like doxy or this. So it's a bit confusing. The strep, the non-susceptibility are high. That means they are resistant strep. So I want to bring this out because we always use tetracycline ointment, right, for wound. right? 1% is for the eye, 3% is for the skin. So to me, so it casts doubt. So I really don't believe in the antimicrobial property of the tetracycline. The only thing works is because it's ointment, okay? Because trap moisture. But then again, if you put ointment onto, have you tried putting ointment onto a wound? It's very difficult because it's watery. So the oil doesn't stick. You apply you apply very hard to let the thing stay. So the usual thing, sometimes I advise patients to put on the gauze, you apply on the gauze, then you put on it. All right. So I don't like tetracycline ointment actually. Okay. If you get a choice, then I will give all the physitic cream, chlorhexidine. It works the same. Okay. I'm not talking about oral, but oral, they say that a very high success rate with outpatient skin and soft tissue infection. But I think this group of medicine is mainly used for things like very atypical, like acne, STDs and things like that. I think they save it for that reason. So nobody use it for wound infection. Silver sulfadazine is classically used for burns, right? Okay, actually, it causes this is called staining, when I'm doing private practice, the Caucasian or the Eurasian, they are fair-skinned people. You go and apply silver sulfadazine on their face, then suddenly they change. They look like panda. Then it's a nightmare. So it's actually I get very agitated over this. I very stressed over this. So I do not use silver sulfadazine on burns. Okay. The only advantage is that, or disadvantage include each pain, there's sloughing of wound surface and require frequent changing. Okay. The only advantage is silver sulfadazine is a very big tube. It's almost this size. Okay, big tube. The only advantage. Okay. But again, I don't think these days we should use it because we have all this chlorhexidine and fusidine. If you want to use cream for these burns and all that, or wound. Okay. So I think it should be out of favor soon. Okay. So next, I like to go back and I like to talk about penicillin or amoxicillin group. So we always use it for wound infection, but remember, we need to give it TDS, 625 TDS augmentin, not BD dosage. Okay. Remember the contact time, because you do not have enough in the blood to go to the designated area. Okay, it has no use. The efficacy is no use. And just to mention, last time people are allergic to penicillin, about 20 years ago, we used alternative erythromycin. Now it's already, by that time, we already know it doesn't work, all right, clinically. Okay, luckily now people start using clindamycin in the alternative. That means to change to in alternative of penicillin allergy. Okay, clindamycin, not erythro or not clavitro. We used to do that. Why? Because number one, erythro is bacteriostatic and it doesn't go to the tissue as well. So it's no use. So don't use it for penicillin allergy. Okay? Yes. Quinolone is only reserved for really all allergic and no choice. Then we use quinolone group. Quinolones orally, it does cause tendon to rupture. I have seen cases on that before. So just be aware, especially on a slightly more elderly patient. Okay? Quinolone. Okay. Now this is aftercare. So basically, the most important, I think I didn't put it down, is that if it is like pressure sore, I think turning is the most important. Okay, turning has a problem for those who look after nursing home. One of the way to make sure they turn is that you see, they always, when I walk to my hospital bed, they always say they turn the patient, but you look at the chart, it's different. So what they do is synchronized turning. That means like those synchronized swimming like that. At 1 o'clock, all is on the left side. 3 o'clock is all on the right side. And then 5 o'clock, all in the center. So it's synchronized. That means one look, you look at, you know the time, you know that they are already at the right place. Okay. Then I think this is a good idea to implement. SGH has implemented this. In fact, I learned from them. Okay. So synchronized turning is a good idea for nursing home patient. Okay. So this is important for aftercare. Then we look at two continuum. This is good. You show the patient or the NOK or the helper this continuum. That means you look at red area, 5, you give a scale, then this part will need antibiotics. Okay. This one is not so clear, but you look at this, it's clearer. You tell the patient on NOK or the helper, If it's turned black, wow, that one very teruk. Okay. When this is still observed, red part, okay, KIV antibiotics. Yellow part means need debridement and definitely antibiotic. Okay, pink, like salmon pink, you are good, cool. So you show them this pictorial thing is, a picture is better than 1,000 words. So you aftercare, then you just tell them, hey, look at this, and let us know what color are they now. If you tell us, you see red, better tell us. Okay, yes. So this is a good wound healing continuum to use in aftercare. Okay, the last I like to share a story. This is to end my discussion. Well, this is one of my younger, slightly younger colleague. She is very procedure adverse. She don't like to do a procedure. But this patient is happened to be her grandmother. So it's a gangrenous toe. Now, she is very enthusiastic, very hands-on. Every few days, she changed some dressing. She even wanted to do the vacuum suction. She wanted to bring her grandmother to the hyperbaric chamber for this wound because this is an ischemic limb, okay? But she does it very meticulous. She debride the wound. She will do all sorts of dressing. You look at it, as it this is months, over 9 months. And initially I told her it's impossible to heal. Look at it. How wrong am I? It's almost healing. From this to this, look at this. Okay? So it is possible because she's meticulous. She's really doing it. Of course, unfortunately, the old lady died of pneumonia or something else before the wound totally healed. Okay, this is an almost impossible healing wound, you know. But so this tells me emotionally is a love story and the love for her grandma. But scientifically is what Albert Einstein said. It's not so because I'm so smart. It is just that I stay with the problem longer. Okay, this really echo this part of it, that how enthusiastic and how you are. Okay, unfortunately, after the grandma passed away, she reverted back to procedure adverse again. She don't do any procedure. Okay, so I think the take-home lesson or take-home is that first we must change our perspective, or refresh it, and then a lot of things is possible if we get to know more about it and a bit more hands-on. All right, so with this, I will end my discussion. What next? I think we are discussing maybe a workshop or a conference so that let the vendor all come together and show you all the dressing at the same time. Let them brag about their dressing and how they add things, and so that you can pay more. So
pay now. Pay
yeah,
more,
pay now.
Oh, the dressing has a QR code there.
Yes. So it'll be, I think it'll be good to have a next stage if you want to go on to this wound.
Actually, in August, the similar webinar, we are having something different. Our nurse clinician Annie is going to sorry, we haven't decided who is going to do the talk. But we're going to have more pictorial case studies on how we manage wounds.
That's fantastic.
Real cases.
Yeah,
so
fantastic.
That's for the August one. In July, which is next month, we have neuropsychiatry as well as September.
So in time to come, maybe we'll hands-on. That means you come and do. Then you physically look at the dressing, how they swell up, how they change by the vendor, and how it works better.
Yes.
Okay? Yeah, so I think maybe I can answer some questions.
Yeah, we have some time. There is a list of questions. Maybe let me just curate a little bit. Some of the questions are really very interesting. Okay, there's a question here about dry gangrene. So Wilson, normal saline not indicated for dry gangrene. Why?
Okay, because dry gangrene, we want to keep it dry.
Only
do not be infected. It just basically is a piece of dead meat. We just want to keep it that way, and then hopefully the body will cut it off. That means chopped off. So that's why we use
like that.
We use alcohol, the most toxic, the most obnoxious, the bad agent. So is to make it dry. That's why it's not indicated, because normal saline does not do anything except offload and just isotonic.
Thank you. Okay, Priscilla has a question. Cleansing solutions like dermacin, Octanicept, Pontosan for biofilm. What do you think of them?
Shireen would like to answer this question.
Okay. So Shireen.
No, okay. So actually, I have not used all these things for the. I have not used all these other agent, because these are firstly not easily available in hospital or clinic setting.
Yeah.
Usually we don't need it.
Okay.
Yeah, so I don't have experience with that. Maybe Priscilla, you can talk about this the next, when you are doing in August. It'll be great.
Okay, there was a cat bite wound case, irrigate with iodine or chlorhexidine. What do you think?
Iodine. It's irrigated with iodine. Then after that, soak it for a while, then chlorhexidine.
Okay.
So yeah, usually this is my routine: iodine, chlorhexidine, and normal saline.
Okay, Ziyang, I think she could be a GP. He asked, how should we manage wounds in a GP setting when we cannot achieve complete hemostasis? For example, contact bleeding like fingertips, shaving injury.
So fingertip shaving injury, actually you can use what I suggest, the alginic dressing with silver. Now, what I do usually is that you put that lignocaine in a cup. Then you ask the patient to put inside. Because you do dressing sensitive, very sensitive, the patient will hit the roof one. So you can start by dipping inside some lignocaine. Okay, then after that, you dip a while already, you're bleeding like you bit, or you put a gauze wet with lignocaine, you put it on it first. Okay, then you soak it for about a while, then you bandage it, right? Then after a while, then you take out, then you ask him dip in iodine or chlorhexidine, you wash it like that. So you don't then touch it, you ask him to touch himself. Okay, so then he can only blame himself, right? So you just do it chlorhexidine. Then after that, you can use the alginate with silver, put it on, then bandage it. It stop bleeding. Yeah. Then deep ulcer, it depends. Like I said, you can inject it with adrenaline. Then if you want to cut it, then you can cut it. Yeah. So you can. Yeah. So actually in ED, this is what we do. I do for them. So you just remember, you put a gauze, you drip the lignocaine, then so you bandage it first. Then after that, you take out, you put a cup or a sterile one, you put the iodine, chlorhexidine, you go and stir inside for a while. Okay, 2-3 minutes. After that, you cut a piece of the alginate, put on, then put gauze, bandage it. Okay, then see him in 2 days and then give antibiotics. You'll be okay. You'll stop, bleeding will stop. Don't use adrenaline for this. Yeah.
Okay, another one is about the dressing. You mentioned that stuff inside the wound.
Yes, that's the alginate.
Alginate. Okay.
Yes, the alginate group. This Biantin has it. Many brands. This what do you call Mepilex also has it. Yeah, there are many brands. Yeah.
So someone wants you to repeat what you talk about hydrocolloid application. Can you apply on acute?
Okay, hydrocolloid is a plaster. So usually it's duodenum. Last time they got another brand, but the outer layer is not so pliable. The duodenum one is movable. So let's say you have an abrasion. So what actually you can wash it and just paste it on. That's it. You just change it every 2-3 days. Okay, until it swells out. It will juice. But because there's a lot of juice, people don't like it because it will start to leak. Right? So what you can do is that you put like other sponge. If you really want to, for example, my son, I'll put sponge dressing, suck first, right? Change every 3 days, 4 days. Okay. Then after that, it's a bit drier already. Then I put the duodenum. That's it. Okay. So one of the way I always like you have someone who have not so much of this solution. I ask them to boil water. Do not change container after it's cooled down while it's still boiling. But the water must tell them, must reinforce, cool down water first, then you put on the wound. Some people thought you boil water just straight away pour. Okay, that one is barbecue different. So you must boil the water, cool down. Okay, don't change container after it cool down. Then use this to wash the wound. Then you just cut one piece of this to put it on. Okay, like hydrocolloid. You can wash it if you don't have other resources. I mean, if you have, then you can put chlorhexidine, normal saline, dry it, then put a hydrocolloid. Then the hydrocolloid must be at least 0.5 cm in the margin around it. You must cut it much bigger. If it's gravity dependent places, you must cut 1 cm at least. Okay, yeah. But some patients don't like it because it leaks. So you just change more often. The other thing I forgot to mention is that we think the dressing is very expensive. But you can imagine if TG need to change every other day, the patient had to line up, take a bus, or go to bedridden one. You or the home nurses need to come every day. The cost is much more expensive than our $12. The dressing $12. Although the dressing is more expensive, because all these dressings sometimes it can keep up to 7 days, and it's easy atraumatic to change. So you use the cool boiled water, pour on it, or you buy chlorhexidine, pour on it, bit of normal saline, take out the dressing, then put back a new one. That's it.
Mm.
So it saves a lot of time, although the dressing itself is expensive.
Mm. Okay.
So I hope I answer your question. Yeah.
Yeah, thanks, Wilson. There are a few other, I'm just choosing those that are more relevant. Like there's the one asking about application of barrier cream. I suspect maybe a nurse will be more suitable to
Yeah,
answer.
that's right.
But this one, by
do you just apply, or do you apply on your hand until you get the oil and apply it?
you-
The barrier cream actually is different. You just apply because there's no wound. Unless you're using, we don't use critic barrier cream for wound, right?
Hmm.
Yeah, we don't use it for wound. You just apply on normal skin. So you just put on patient, then you rub it. That's it.
Yeah.
This is how I feel.
Yeah.
And we don't usually use it on wound. Yeah.
So the other one is about medical debris. You mentioned about hydrogel. Can you explain a little bit?
So what you do is that you use the hydroactive gel, put on the places that you, okay, let me, you imagine, have you had a wound or scab, then you go for swimming. Then what happened to the scab? It becomes softened and then it dropped out.
Yeah.
Okay. If you didn't drop out, that means you didn't swim long enough. You have to swim longer. So it's the same thing applied, that the medical debridement means that you put all this hydroactive gel. Coloplast, I mean, different brand, Coloplast also have. It just name a few. This, what do you call it? Convertec also has, which is the usual, like, what do you call it? You apply on it, then you seal it off with using a Tegaderm.
Yeah.
Then that's provided the wound is not actively, what do you call it, infected. Okay. So you put it on. Then after 2-3 days, you take out. Then the thing, you see that it will soften out already. So you actually can wipe it off. If you don't, then you put the gel again, you put it on the Tegaderm, seal it off again. Okay. Now, some of the vendor will tell you that actually you can put hydrocolloid on top of this gel and all that. It's just more and more dressing . So for me, just Tegaderm one piece, put on it, seal off. Okay. Then after that, you wait 2-3 days, you take out, you clean. If not enough, you put some more, you just seal off. This is called debridement. Until the white and the dead part becomes soft and you take off.
Those are the biofilm. We're talking about the slough. Okay.
This pomade tea, I don't know what it is.
Okay, I think, yeah, there are so many brands. This one, the other one, malodorous wounds. How do you manage the community?
Okay, so we need to understand that. Okay, malodorous come from what? Bacteria, right? I mean, infected or dirty wound. So firstly, you see whether need debridement or not. So you seal up with iodine, wash it properly first. Then if you need debridement, either you use medical or surgical. Okay. Then after that, then you wash it with some more iodine and chlorhexidine. Then you apply the appropriate dressing. Depends on what kind of. Let's say if the wound is very dirty, one setting you cannot debride all, so you wash it off, take out whatever you can, or you can't, then you just put the this hydroactive gel, seal it off. A few days later, you come back, 2-3 days later, you debride again. So once you get the debridement, the wound will be not smelly anymore. Of course, market, there's a lot of activated charcoal dressing also. They claim to remove smell also. Yeah, this is a shortcut. But as long as you have dirty things on it, have wound, have biofilm, has all this dead tissue, sure smell. You need to remove it.
So I think we have time for only one last question.
Yeah.
I've chosen the one by Dr. Lim Gyok Bin. For burn caused by hot steam and oil with blister in the GP setting, can you use duoderm film after cleaning the wound?
Okay. Now this is an interesting thing because last time we used to put Tegaderm on it. Okay, Tegaderm itself, actually, you read the line, they says that it allows vapor transfer. But I don't know what vapor is it, but it's just all seal up. I don't know what do you mean by the vapor. So the wound actually will be macerated. But for burns, you seal, after you clean it, you seal up, all right? Last time, when the burn center, there's 20-30 years ago, what happened is that they don't remove the Tegaderm. They keep the Tegaderm. If it's too tense, they poke it, then they put Tegaderm some more. There's two advantages. One, the fluid, they retain it. Two is that it's transparent. You can see pus collecting. That's the reason why. So you put Tegaderm. You know what I mean? Last time. But now, the Tegaderm is not meant to put, then tomorrow, 2 days later, tear out. Then the blister will all come up. Okay? So if it's small blister, you don't have to put anything. Small blister. If it's tense, and arbitrarily larger than 3 cm, you can puncture it, poke a hole. Then you can put an absorbent dressing. Don't put duodenum because it cannot suck the fluid. It's not enough to suck the fluid. So you put an absorbent, can be anything.
Like foam or
Sponge.
alginate.
Foam and all that, it'll be good. Then the skin will slowly, because the swelling, the blister will slowly regress because got outlet.
Yeah.
Right? Then after that, the skin will stick back. Of course, the skin eventually will die off, but it's the most natural dressing. You just put the foam to absorb whatever.
Okay.
So don't put duodenum unless it is already a hole.
Yeah.
Then you can put duodenum straight away. No problem. You clean it, put straight away. That's no problem.
Yeah, thank you. I think we only have time for this. And thank you so much, Wilson, for sharing generously your research and practice and real examples, and your perspective is really, really different from the time when I was studying geriatrics. So it's excellent. Thank you. And there are many other
I'm
questions.
forced into this, no choice.
No, of course we are doctors. I mean, we have to do this. So thanks, Wilson. And so next month we have one on neuropsychiatry, and then we are going to have a wound talk again. Then the month after that is another one on neuropsychiatry. So there are many of you who are very interested. I think we will be sending you email just to let you know. But anyway, with this, let us thank Dr. Wilson Chong for an afternoon of very informative and very enlightening lecture on wound management. Thank you very much, Wilson, and may you enjoy your week ahead.
Thank you. Thank you.
Thank you. Thanks.
Okay, bye-bye. Thanks, Christine.
Bye.
Bye-bye.
Thank you. Thank you all. Thank you.